On-the-scene video coverage of TCT 2012 is supported by Pradaxa.
Thank you, Professor Moran. It's a great privilege to stand up here and give the first presentation of the XIMA investigators. My co-colleague, Professor Jose Maria de la Torre Hernandez, is also here with me in the press conference. The XIMA trial is a play on words in English. A XIMA frame is what's used for elderly patients to walk around. I think they're called walkers in America. But that's the purpose and name of this trial, and that's where it's come from. This is a prospective randomized trial of Everolimus-Eluting stents versus bare metal stents in octogenarian patients. And it's called Science or Vision for the Management of Angina in the Elderly, which is where the XIMA comes from. These are my disclosures over the last year. It's important to emphasize this trial was funded by an unrestricted educational grant from Abbott Vascular. Healthcare has improved sufficiently that its increasing proportion of elderly patients are now coming to the fore. It's an increasing common clinical scenario to have an elderly patient with extensive comorbidity, refractory angina, complex coronary anatomy that is unsuitable for various reasons for coronary artery bypass surgery. Whether or not bare metal or drug-eluting stents are useful in coronary disease has been answered, mainly by the ARTS-1 and ARTS-2 trials. But one has to remember the mean age of these patients was 61 years. And is it appropriate to extend the findings from these important trials to patients who are 2, nearly 3 decades older? Octogenarians are often excluded from clinical trials for good reason. And what does exist is scanty data on retrospective, single-center, small sample series with variable results. We intended in this trial to investigate the hypothesis that drug-eluting stenting of coronary disease causing limiting angina will be superior to bare metal stenting in terms of a combined endpoint of mortality, MI, stroke, requirement for target vessel revascularization, and severe hemorrhage at 1 year in patients aged 80 or above. Drug-eluting stent technology would seem an obvious use in patients who have complex coronary disease. But the other side of the coin is elderly patients will then be committed to 1 year dual antiplatelet therapy. This may lead to bleeding, and if patients who are elderly bleed, the consequences of that bleeding are usually very significant. You may have in-stent restenosis in a bare metal stent, but it may well be that the clinical consequences of that may be sufficiently unimportant for a patient who has limited physical capability. There were 22 centres across UK and Spain, and I'm grateful to Professor de la Torre Hernandez to make this an international study. And over 2 years, the last enrolled patient was in August 2011. We managed to accumulate 800 patients, 400 from the UK and 400 from Spain. This is the bottom line of the primary endpoint. There was no difference in death between the two groups. There was no difference in major hemorrhage, despite the different dual antiplatelet therapy regimes that two groups required. Myocardial infarction was increased in the bare metal group, as was target vessel revascularization, both of these proving significant p-values. And the incidence of stroke in the two groups was no different. The primary endpoint was 18.7% in the bare metal group and 14.5% in the drug-eluting stent, and the p-value was 0.092. This is represented on the Kaplan-Meier survival plots for time to first event here, showing the difference in the two arms, mainly driven by MI and TVR. We can conclude that this prospective randomized trial comparing bare metal and drug-eluting stents for octogenarians requiring stenting for coronary disease has shown good clinical results with drug-eluting and bare metal stents. No difference in mortality between the two groups at 1 year. Statistically similar rates of major hemorrhage in both groups despite differing DAPT regimes, but significantly lower rates of TVR and MI among the DES-treated patients. Thanks very much.
So this paper is open for any questions from the press.
Can a panel member ask a question?
Yes, we'll come back, but we first give the right to the floor. Please, please introduce yourself and.
Hi, I'm Michael Reardon with theheart.org. If you had to balance between sort of the risk of bleeding and you're also seeing an increase in the risk of MI, how do you put this sort of into context for clinicians that may have an elderly patient? Like, what would your recommendations be based on these data?
Well, it's a common theme to have the discussion that elderly patients are having bleeding events, but they've left hospital. They're usually away from the center that put the stent in. And to be honest, there was very little data in understanding what the risk was, although there was a concern that it was a very significant risk for this particular cohort of patients. What's reassuring is that the severe hemorrhage rates were a little low. I haven't shown you the sub-analysis, but it shows you that between 6 months and 12 months in the drug-eluting stent group, there was 1% severe major hemorrhage, 0.2% in the bare metal group. But overall, the severe major hemorrhage between the two groups wasn't as significant as we thought it might be. And I think this is very useful data for patients, perhaps can be reassured from this, that if they do want to put drug-eluting stent technology in elderly patients, that the consequences of this are not as significant as we thought it might be.
Is the risk in MI that you're seeing in sort of the primary endpoint, is that concerning to you? Or how does that balance out against sort of the reduction in bleeding versus, you know, the increased risk of MI?
Yeah, the bare metal group, I suppose my thought initially that the in-stent restenosis that we saw in the bare metal group might be relatively silent clinically has actually translated into important myocardial infarction events. And so that's an important finding from this study in terms of decision making.
Dr. Miller? Sorry.
We've got, well, I think she's first. Yeah. You're fine. Okay.
Ed Sussman from PhD. If the target vessel revascularization, was that angiographically driven or symptom driven?
This is clinically driven. Yeah, we didn't do serial angiograms on these patients.
Any other questions? Yes.
Bert Cohen from angioplasty.org. Again, I've asked this question all the time. Definition of bleeding. This was not access site bleeding.
No, we use the TIMI. What I've presented is TIMI major,
Okay.
as a definition of severe hemorrhage.
So just to follow up, what was the rate of TIMI minor? Because while TIMI major is extremely important, but so is TIMI minor, especially in the elderly.
I haven't presented that data, but it's 3% in the drug-eluting stent group and 2% in the bare metal group.
Okay, that's quite low. Okay, so let's come to the panel. Dr. Gray, you had a question. Dr. Silver.
Yeah, Dr. Bella, very important study, of course, because elderly as an inclusion criteria. So the primary endpoint was not met.
Correct.
Okay. So what is your conclusion? Should we prefer drug-eluting stents in the elderly or not? I mean, the major the major component of the primary endpoint was target vessel revascularization, and this was highly significant different. And I can imagine for elderly people, it's a pain to come back again on the cath table. So I would say yes, in general, if there's no contraindication, you should go for drug-eluting stent, even in patients over 75. What is your conclusion?
I think we're reassured by this data that the outcome actually for both groups was pretty good. Some of the registry data shows incidence of much greater events than these that have been reported. So whereas the primary endpoint wasn't met, analysis of the data shows that TVR and MI of the bare metal group is a clinically important endpoint that we should decide. I'm reassured by these data that drug-eluting stent technology will be of benefit to this age group.
Congratulations. This is a very important study, common problem we all face. Stent thrombosis rates between the two groups, do you able to tease out that?
We haven't been able to tease it out. The main problem is the difficulty in the mortality patients. A lot of the deaths were difficult to get specific data from rural Spanish sites, and the reason I haven't presented it is because we're working hard in trying to nail that. But I'm not sufficiently comfortable with the data at the moment to say. It looks like, certainly from the UK data, that it's low, but I can't give you a specific number at the moment.
Bill?
I think I always love to see a trial that takes on excluded patients from other trials. And when you take on a group of confounding patients, and I think you give reasonably clear data, I think it's important. And especially, as everybody said, this is a difficult population that we all deal with. So congratulations. First, do you have data on dual antiplatelet therapy at 3, 6, 12 months? I think that's important to know as one of the major components of the endpoint is hemorrhage.
One of the major concerns was compliance in this challenging group. And whereas the compliance was excellent, it turns out, that may well be because of monitoring in association with the trial. And whether or not this can be related to the day-to-day clinical practice will have to be borne out. But it does emphasize that if you are able to set up systems which can encourage good compliance, then you get good results.
And it also bears on the hemorrhage in the trial. That is, if there was only 70% of the patients at 6 months actually taking dual antiplatelet therapy on the DES side, that will change your conclusions, obviously.
Yeah.
But I think, just one last comment, I think that this is a broader issue because patients who are older tend to have multivessel disease, and so this opens up the door for them from a safety perspective, if nothing else. The alternative would be bypass surgery, which in this population would be incredibly difficult. So this is a very important study, I think. Even though the endpoint wasn't met, I agree with Sigmund. I think you look at the time to event charts and you say that this is clearly, there's a differential here that's going on. And again, congratulations.
Thank you.
Congratulations. If there are no other questions, we'll move forward. Thank you. Thank you very much.